morning, and thank you for having us. By way of introduction, my name is Daniel Douthit, and I'm here with two of my colleagues, Amelia Ndeli and Camille Grant. Together, we are CED Consulting. We're excited to be here today to tell you our recommendation for how Kaiser Permanente can continue to grow in the Central Valley while meeting the needs of their most at-risk populations. Before we begin with the presentation itself, I'd like to walk you all through our agenda so that you have an idea of the direction that we're trying to move in. First, I'm going to walk you through our introduction, which contains our market analysis and our executive summary. Then we're going to do a deep dive into each of our recommendations. The next thing we're going to look at is the implementation process, which includes our timeline and financials. Then we're going to conclude our presentation and open up the floor for any questions that you all may have for us. So upon doing our internal analysis of Kaiser Permanente, as well as an external analysis of the market and the competitors, we have identified 4 hurdles that Kaiser Permanente has to overcome if they're going to continue to be successful in the Central Valley. The first of these hurdles is the increased demand for primary care. By the year 2018, there is a projected demand of an additional 14 provider offices. The second hurdle that needs to be overcome is the underutilization of urgent cares. Currently, there are 2 urgent care offices in the Visalia Medical Office Building that are being underutilized. Furthermore, up to 71% of Kaiser Permanente plan holders are getting their urgent care services from another facility. The third challenge that we have to overcome is the increased demand for inpatient services. By the year 2022, there's an increased demand for an additional 50 inpatient beds and 5 operating rooms. And the last challenge that we have to address is the shortage of physicians in the area. Our research has shown that this trend is prominent across the entire country. However, it is extremely prevalent in rural areas like the Central Valley. So we recommend implementing the blueprint, a 3-pronged approach that's going to help you all address these 4 challenges that we've just mentioned. The first component of the blueprint is to implement a hoteling model within the medical office building. A hoteling structure is going to help you all become a little bit more operationally efficient to help meet that primary care demand. The second component of the blueprint is to invest in an ambulatory care center. An ambulatory care center is going to give you all a centralized location for providing both specialty and outpatient services. And this includes outpatient surgery. The third component of the blueprint is to leverage the contracts that you all currently have with other non-Kaiser Permanente providers in the area. This is going to allow you to create strategic partnerships so that you can better manage the health of the entire population. We believe that by implementing this 3-pronged approach, not only can you meet the short-term and the middle-term demand of the Central Valley, but you can help manage the health of the entire population across the entire continuum of care while staying financially responsible. Now, with that being said, I'd like to turn it over to my colleague, Camille Grant, who's going to tell you all a little bit more about our first and second recommendations.
Thank you, Daniel. Our first recommendation is for you to implement a hoteling model in your medical office building. A hoteling model is one in which your providers are not given a designated office. However, they are allowed to rotate freely between offices and exam rooms based upon need. Presently, you are staffing your medical office building on a 1 provider to 1 office ratio. Each provider is responsible for 2 exam rooms within each office. This means that while one person is receiving care, the other one has to wait. By transitioning to a hoteling model, you allow yourselves to increase your provider count by 1. This not only allows you to use the full capacity of each provider office if need be, but allows both patients to be seen simultaneously. Research has shown that by decreasing patient wait times, you increase patient satisfaction. Furthermore, an increase in patient satisfaction leads to an increased likelihood that that patient will return to you to deliver their care. While performing our internal analysis, we've assessed that you presently have 29 provider offices within your medical office building. Understanding that you staff these offices on a 1 provider to 1 office ratio, we can assume that at any given time, you have 29 providers delivering care to your patients. By transitioning to a hoteling model, you increase your flexibility. As my colleague Daniel noted previously, you are facing an increased demand of 14 additional provider offices within the next 4 years. A hoteling model will allow you to meet this demand while increasing your primary care throughput. In addition to that, a hoteling model will allow you to use your full capacity without taking on the additional risk and costs that come with constructing additional offices. In summation, there are 3 key reasons why we believe and why we strongly feel as though a hoteling model is the ideal model for your medical office building. These 3 reasons all lead to a leaner medical office building. The first reason is that you are able to increase your primary care throughput as well as meet that demand you are facing in the future. Secondly, you are able to increase your flexibility. We realize that in healthcare, nothing is definite. So flexibility is the key to making yourself a strong competitor in your present market. Last but certainly not least, the third reason why we believe that the hoteling model is the ideal model for your medical office building is because it encourages collaboration. By breaking down metaphorical walls, you allow interaction between your providers. Research has shown that provider interaction leads to innovation, which leads to better patient outcomes. Our second recommendation is for you to invest in an ambulatory care center. An ambulatory care center provides outpatient services as well as surgeries spanning across a number of specialties. National trends show us that in the next 10 years, we are facing an increased demand for outpatient services. Furthermore, 60% of all hospital revenues are derived from outpatient services. Sub-market trends show us that you are presently spending approximately $16 million to non-Kaiser Permanente facilities for outpatient services. Furthermore, almost 71% of your members are receiving their urgent care at non-Kaiser Permanente facilities. By investing in your very own ambulatory care center, you open yourselves up to a multitude of opportunities. One such opportunity is through the collaborative care that is offered in your ambulatory care center, you are better able to manage the health of your population. Secondly, by strategically locating your ambulatory care center at a place that is most accessible to your patients, you are able to address one of the top needs of the Fresno area, which is access to care. Lastly, your very own ambulatory care center will allow you to address a number of the top needs, as noted in your community health needs assessment for the Fresno area. In order to determine the best services to offer in your ambulatory care center, it is essential that we reflect upon the current services that you offer in your medical office building. Presently, you are offering 5 primary care services in addition to 2 specialty services. These 2 specialty services, dermatology and mental health, are offered via telemedicine. We recommend that you shift these specialty services out of your medical office building. This will allow you to transform your medical office building into one cohesive place dedicated to primary care. In shifting these services out of your medical office building, we recommend that you place them in your ambulatory care center. These 2 services, in addition to 5 other specialties, were selected because they help to address the needs as noted in the Community Health Needs Assessment for the Fresno area. In addition to this, these specialties in collaboration will allow you to create a centralized location dedicated to specialty care. And with that, I will pass it off to my colleague, Amelia Indeli, who will discuss our third recommendation and the financials.
Thank you, Camille. Our third recommendation is for you to engage in a strategic partnership in order to leverage existing contracts with the 3 inpatient facilities in the area. Kauai Delta, Tulare Regional, and Sierra View all currently provide you inpatient services, skilled nursing services, and observational bed use. In 2013, you paid $23 million to these facilities in out-of-network claims. Now, due to the outpatient nature of our first two recommendations, we believe that this number can significantly be reduced. However, we do see an opportunity for you to also reduce the claims associated with inpatient services. In order for these three facilities to engage in this strategic partnership, it's important that mutual benefit is derived. They must understand that this is a win-win scenario. In order for you to utilize these facilities as an avenue for inpatient care and address the increased demand in inpatient services needed at a lower rate, we recommend that you engage in a longer-term contract with these facilities and also share your robust payer and provider data. Engaging in a longer-term contract with these facilities will allow them to lock in a cost-plus rate in a dynamic environment that's moving from fee-for-service to value-based care. We also recommend that you share your robust payer and provider data. Sharing this data will allow these facilities to conduct both market and academic research in order to position themselves correctly in the market. Studies have also shown that leveraging this data can reduce hospital use and both emergency room use. Let's take a look at our financials. Engaging in the blueprint will allow you to realize a net present value per member per month of $18.84, a total NPV of $19 million, and an internal rate of return of 13%. In order to come up with these numbers, we use a growth rate of 4% and a cost of capital of 10%, which is consistent with the cost of capital of nonprofit providers in the California area. As you can see on our incremental cash flows graph, the biggest capital expenditure takes place in 2015. This expenditure is due to the increased providers needed for the medical office building, the $100 million estimate that we have assumed the ambulatory care center will cost, and things like insurance for the ambulatory care center. We recommend that you continue to hire providers through 2018 for the medical office building, at which time the ambulatory care center will be open for all of your members. As you can see in 2017, cash flows become positive. This positive cash flow is due to the increased revenue derived from the increase in providers in the medical office building. Now, in order for us to give you a holistic view of your financial possible situation, we conducted a sensitivity analysis. We wanted to provide you both a bear and a bull market scenario. In a bear market, we assumed a discount rate of 13%, which accounts for risk. Even at this 13% discount rate, you're able to realize an NPV of 82 cents per member per month. In a bull market, we lowered that discount rate to 7%, allowing you to realize an NPV of $42.72 per member per month. Due to these figures behind me, you can see that in a weak market or a strong market, the blueprint is the answer for you. I'll now pass it off to my colleague Daniel, who will conclude our presentation.
Thank you, Amelia. So in order to successfully engage in the blueprint, there are a couple things that we need to begin doing immediately. And the first thing that we need to do is begin recruiting physicians and other providers to staff our medical office building. If we want to expand that beginning in 2015, we want to start looking for that talent now and incentivizing them to come to the Central Valley. The other thing we want to begin doing immediately is to start planning the logistics of actually building this ambulatory care center. The exact location where it's going to go, the design, and how it's going to be carried out is going to be something that's crucially planned over the next year or so. Lastly, the thing that we need to begin doing immediately is start looking at how these contracts with the other providers are going to expire and how we can start developing those relationships. We currently have strong, long-standing relationships with these organizations, and we want them to make sure that we want to keep that avenue going. Beginning in 2015, we will open the medical office building for its hoteling structure, and we will continue to add physicians until the year 2018, where we will reevaluate how well we met that initial demand for primary care, and then adjust as needed. Construction for the ambulatory care center itself will also occur by the end of year 2015, and we've allotted up to 2 years for construction, where in 2018, that ambulatory care center will open for business for the entire Kaiser Permanente community. Now, there are a couple things that we want to make sure Kaiser keeps in mind when they're looking to staff our new facilities. And that's how are we going to recruit, engage, and retain our providers. We recommend that by targeting a mix of new physicians as well as advanced practice providers such as nurse practitioners and PAs, and offering them signing bonuses and ensuring that they know about the loan forgiveness systems that we actually qualify in the Central Valley, we can help acquire new talent without compromising the risk of increasing the salaries of the entire rest of the Kaiser Permanente staff. The second portion is how do we engage these providers? And by providing them an opportunity for professional development and education seminars within our organization, we can help nurture and develop talent from within the organization to become clinician champions so that they better understand how to coordinate care, so that they better understand how to collaborate with one another, and so that they understand how the administrative side of the organization works so that they can lead ourselves to greatness from within. The last portion is the retention of our clinicians. So by doing things like creating this ambulatory care center and making sure they are aesthetically pleasing, bright lights, open spaces, windows so that the patients can see outward, and perhaps even a corporate gym, we can create a facility that our providers actually enjoy working in, a place where they want to provide care, and a place where they want to be. Now, as we conclude, we would like to highlight a couple of the strategic alternatives that we have considered but did not pursue. The first was to build another inpatient facility. And while this did help meet the needs of a broad spectrum of people, it was financially a little bit expensive, and it was also very difficult because we had 3 other competitors who had inpatient facilities within the region. One of the other options that we considered were building freestanding emergency departments or urgent cares. And while these were more fiscally feasible, they only addressed the needs of a certain subset of our population, and that was the patients who need care immediately and right then. That is why we have decided to approach this from the 3-pronged approach of hoteling in the medical office building, building the ambulatory care center, and leveraging these contracts. Not only is this an option that is financially feasible for Kaiser Permanente, but it does so that you can manage the care of the entire population and across the entire spectrum of their care. Now, the last thing that we would like to do is go back to those 4 hurdles that we said that Kaiser has to overcome if they're going to continue to be successful. The first of those hurdles was the increased demand for primary care, and we believe that by implementing this hoteling model, you will not only be able to meet that demand, but you will be able to track how well you're meeting it and adjust as needed. The second hurdle that we had to overcome was the underutilization of urgent cares. By shifting those urgent care facilities into our new ambulatory care center and strategically placing that in a geographic location that's a little bit more accessible to our patients, not only do we expect to see more utilization, but we expect to see more appropriate usage of the urgent cares. The third hurdle that we had to overcome was the increased demand for inpatient services. By leveraging these contracts and making sure that we have a strategic partnership with other organizations in the area, we have created an avenue for our patients to go if they absolutely need inpatient care within the Central Valley and cannot make it up to the Fresno Medical Center. And the last thing that we'd like to highlight was that physician shortage. Again, by targeting mid-level providers, advanced practice providers, as well as young physicians out of the area, we believe that not only can we recruit strong talent to work at Kaiser Permanente, but we can begin to cultivate that talent and really have them grow our organization from within. And with that being said, we'd like to thank you for letting us present to you all and open up the floor to any questions that you all may have for us.
In your hotel model, you said you were going to reduce wait time by hiring more doctors. And I know that the shortage is an issue, but also not having, like you said, 71% of your patients seeking care outside of Kaiser. So by doubling up on docs, how does that solve the access problem?
So in terms of the access, I'm going to speak from behind there so that we don't get a little bit of feedback. In terms of the access problem, there's a couple things that we wanted to highlight. And as you can see here, the blue stars represent Kaiser Permanente competitors in Visalia, Tulare, and in Exeter. This right here represents currently where the medical office building exists right now. We believe that by providing this location as well as the ambulatory care center a bit closer to the center of Visalia, where we're getting a lot of competition from Kauai Delta, we've opened up the access to where the patients can get their services, particularly the majority of our patients, the Kaiser Permanente patients themselves. In terms of actually staffing the model, we believe that because you are increasing the capacity of the medical office building, instead of giving them that wait time that they're typically used to accustomed feeling while one physician is seeing one office, you're also increasing access in terms of how quickly they can get to a physician.
So I wanted to stay on the hoteling model a little bit.
Go ahead.
So I think it's an idea, but for the doctors, it's going to represent change. And I did a little number crunching, and it looks like if you just say 9 patients per shift, by incorporating this model, you go to potentially 6 patients per provider per shift. So realizing that there's some compensation based on production, that's going to be a decrease in production for the physicians. So while this may be a positive change for organization as a whole, how would you sell that to the doctors, realizing that they may see that impact and come?
We don't foresee the doctors seeing less patients. There's several options actually for these doctors to see patients. So I just want to reset the scenario of what a hoteling model will look like for you. So currently there's 1 office, 2 exam rooms. The doctor is seeing 1 patient and the other patient's waiting. In the hoteling model, the office is an area for all physicians. So any physician can come in and out of that particular office, not the exam room. So if we have another physician in that office, 2 patients can be seen simultaneously. Now, if the issue comes up of changing the rooms over for the next patient, maybe that reduces some time. There's several other offices that are open, and that physician can move to those offices if need be. So really, the amount of patients seen in a day should not change.
Right, and in addition to that, we realized that with change comes change management. So of course, making our providers aware, making them comfortable, making sure that they fully understand what the hoteling model is, but also helping them revisit the reason why we come into healthcare, which is better patient outcomes. And in order to attain better patient outcomes, we need to reduce wait times.
So part of the challenge is our patients going to other facilities. Is it our understanding that access is the issue, and if we have more capacity, they would just automatically come to us instead of the others?
Yeah, sure.
So one way in which we feel as though we're going to be able to address the issue of bringing our patients back to us is through our 4-legged marketing strategy. And our 4-legged marketing strategy is also dual language, because we realize that 25% of our patients in the Central Valley region speak solely Spanish in their homes. So that marketing strategy targets specifically different age populations. So in order to target our 64 and under population, we plan on leveraging existing technologies such as social media, text messages, push phone calls, voicemails, and things like that. In order to target our 65 and older population, we plan on advertising at faith-based community centers. Research shows that 60% of all seniors 65 and older attend church every week. So we think that this is a great location to target them. We feel like direct mailings will attract all of our patients, as well as allow us the opportunity to place in their hands physical dual language reminders to come back to us. We're here. We've made some new changes, and we realize that people like new things. So we hope that that newness will draw them back to us. And our last approach is to really identify key leaders, physician leads, as well as nurse practitioner champions. We feel like they are creating weekly or bi-weekly or monthly educational training programs that address your top needs. Let's say in May you cover diabetes education. This will allow you to build closer relationships with your patients, allow you to better manage and coordinate their care, but also be another factor that draws them back to you.
Thanks.
So speak to me about the strategic alternative. I see here on slide 22, You mentioned the amount of dollars spent in outside claims and the high utilization of the ED. Why wouldn't you choose to invest in that urgent care strategy and maybe leverage that MOB for expanded access hours in the urgent care space, recognizing that that's driving some of those profitability concerns?
Yeah, sure. I think I can speak a little bit to that. So we already realized that they have recently expanded the hours in the medical office building. So despite the fact that we've recently expanded those hours to accommodate the additional flexibility, we still didn't see an additional uptake and utilization right there. Furthermore, we do realize that a huge portion of the people who are incorrectly using non-Kaiser Permanente facilities are those older populations. And the older populations tend to not be as well educated in terms of when to use urgent cares and when to use those freestanding emergency rooms. That's something that we're trying to achieve by approaching this three-pronged approach so that everybody understands when to better utilize those situations. So unfortunately, by just putting those freestanding EDs or those urgent cares, we didn't feel like it would quite capture those people who were incorrectly using the services as well as perhaps the blueprint would have done.
Furthermore, to go back to the location of where we designated these facilities to be, 71% of Kaiser members are going to out-of-network urgent cares. So bringing the urgent care closer to them, we feel would alleviate some of this issue because the urgent care is going to move into the ambulatory care center.
All right, go ahead, Denise. Go ahead.
My board members are not. 'Cause I'm so shy, I can't get to the mic. My question really was just going to be about your strategy to have in your medical office building primary care services only, right? In your ambulatory facility, you talked about the multi-specialty care. Talk to me a little bit about why not blend the care delivery model in both or one of the facilities?
Yeah, I think to a certain extent, you need to keep some sort of differentiation between the two types of care, just because we want to try to manage those primary care issues in one location before it blows up into something like secondary or tertiary care and we have to get it to a hospital. By allowing those physicians who are specifically managing those primary care demands, we can kind of hone in those who are going to specifically collaborate within those organizations, and then those can specifically collaborate within the specialty care. And we think furthermore, that this advancement in technology, because both of these organizations are going to be on the Kaiser Permanente electronic medical record system, the exchange of information between the two is going to be significantly facilitated, despite the fact that they are geographically separated.
So this is just my follow-up question. What's the geographical distance between the two locations?
Approximately 6 miles.
6, okay, thanks.
But why would you not want to foster that collaboration immediately between primary and specialty care for maybe some immediate follow-up consults to those patients that have arrived on site, and then maybe allow them to be admitted as appropriate to the appropriate tertiary facility?
Right. I think that's definitely something a big concern, and it's a definite possibility that we can still continue to do. Again, it's not like there's going to be a wall between the two organizations. We want to encourage information exchange between the two, and we do understand that the primary care physicians are going to understand the physicians that are at the ambulatory care center, what they're good at, what types of patients that they like to see, and can forward those patients over as needed. But we just felt like keeping in two separate locations at that specific time would really help foster a kind of honed-in collaboration with the people that would best, within your peer group, collaborate a little bit better and more efficiently within those peer groups.
And furthermore, just reflecting upon our marketing strategy, we feel as though by holding educational trainings for our patients, the patients who are attending the medical office building will also be invited to those trainings. So that's a way for them to interact and get to know the specialty providers in the ambulatory care centers.
Thank you so much.
Thank you.